Okay, so the first chapter of the cycle was about burns, right? Now, so maybe you all experienced, or some of you have experienced burns in one form or another, no? Maybe the bobora, sunburn mo, or you cook your favorite instant noodles and then the water from the pot, no? Spilled over, no? And nabasag ka. Okay, anyway, so there are three main classifications of burns. So thermal, meaning caused by a certain form of increase in temperature. So a thermal burn can be from flame, from an explosion. No? So anything that involves increasing exposing the body to an increased temperature from an external source would be thermal. So it could be contact burns, right? Like if you touch a flat iron, okay, nagplansya ka, then aminin mo, napalong na, then hindi, Scalp burns, so from a hot liquid. Flame burns. So siguro maybe when you were still very small, kana mong mga kandila, no? Then napasok mo, flame. Okay? Flash burns, explosions. No? Like, common example nowadays are these people who work with LPG tanks. So I've had a couple of patients, usually every year, nakita yung 5 to 10 patients, the LPG tank would explode. No? So there can be also a special category known as electrical burns. Actually, we call them in general electrical injury, because it's not only the burns that are going to be the problem, but the exposure to especially high voltage electricity is going to have a lot of deleterious effects on the body. Then chemical burns. So there's a material which can either be alkali or acidic that can cause damage to the area that it is exposed to. So thermal burns are the most common. So there are flame burns, contact burns, scalp burns. So as long as it is, it involves something wherein there is an object or there is exposure to increased temperature, that is going to be a thermal burn. Now, for thermal burns, these are the ones that are associated with inhalation injuries. Of course, with the exceptions of maybe a scalp burn wherein the fluid, the liquid came into contact with the patient, or maybe a contact burn. Like one example that you might encounter in the future would be these people with riding motorcycles, and then they wear shorts. So the leg, tamas tambutso, pasok. Electrical injury. So there are special concerns. No? Now, when you are subjected to electrical current, the initial response of your body is to be a rapid spastic action. So almost all of the muscles are going to spasm violently. Now, this can create what we call rhabdomyolysis, especially the higher the voltage and the longer the exposure to the electric current. Now, the myocytes, the rhabdomyolysis is going to cause a release of myoglobin into the bloodstream. So, this is going to accumulate in the kidney. So, how are we going to deal with this? We usually dilute the blood. That is why resuscitation is important also in this case. Now, special concerns would be the presence of arrhythmias, because as we know, if we subject the heart to certain electric currents, it is also going to contract or relax in certain ways. So, if you would subject a patient to a certain voltage, then there is this risk of developing arrhythmias also. And another would be compartment syndrome. For compartment syndrome, it would be commonly found in the extremities, like let's say for example, the patient is a lineman. Then he gets to hold an object at the line, which happens to be live. So the electric current is going to go through that extremity and it is going to go out. The point of contact is going to be the area that's in contact where the electricity comes into the body. The point of grounding is where the electricity exits the body. So usually the damage is greater in the point of exit, a point of grounding. Yeah? Now, swelling can happen when the body is subjected to trauma or electrical injury. So for example, since there's violent contractions of the muscles in the, let's say for example, the lower extremity, there's going to be rhabdomyolysis. Of course, there's going to be some form of swelling in the muscles. Also, there's going to be the formation of the word eschar on the skin. So, the skin that is going to be with an eschar is going to get tighter and less elastic. Plus, you're going to add the swelling from within, inside the muscle compartments. And if you remember in anatomy or histology, that the muscle fibers are usually bound within fascial bundles. So if you increase the tourniquet effect of the external compression from the skin and the internal compression from the swelling, the blood supply is going to be impaired, right? So of course, first it's going to be venous. So if you impede the venous side, what is going to happen? Edema. So it's going to swell even more. Then later, the arterial side is going to be compromised, which can then cause ischemia to the limb involved. So that is going to be compartment syndrome. So there can sometimes be neurologic problems that could develop for cataract formation. So for neurologic symptoms, sometimes patients would have tics, sometimes normal movements or whatever. So these are later observed. Maybe sometimes they would not happen, so it really depends. So if ever you catch a patient with certain neurologic problems after electrical injury, then you will have to investigate further. So if you remember in neuroanatomy, you can always localize, levelize, and lateralize the area of concern. Chemical burns. So a few weeks ago, I had a patient, Chinese dude, worked in a factory somewhere in El Salvador. So they were working with a certain chemical, and then he exploded ang tank. So the chemical splashed on his face, both arms, and the anterior torso. So upon evaluation of this patient, I asked him, what was the chemical? Was it either acidic or was it alkaline? And of course, he wouldn't tell me. Company, choo-choo, whatever, no? So then I told him that I have to know, because what's important here is if we know whether it's acid or alkaline, we would know what to expect. Because for an acid burn, it's mostly on the surface, no? Because the surface proteins are going to get coagulated, so they're just going to be deformed, just like cooking an egg. No? But if it's alkaline, it would cause liquefactive necrosis, so it would dissolve the skin and other deeper layers afterwards. And the thing about this patient is nag-usually communicate, na-inject siya. Hello sir, so may Google Translator. What was the chemical? Was it an acid? What you do? Ano siya? Oh, what you mo? So, dalitan, no? Anyway, long story short, the company later told me that it was an acid. So, good thing it was an acid, so we would have to observe any further. Okay? So, chemical burns would also affect the skin or the body in the same way or in a similar fashion as thermal burns. So, the depth of penetration would be determined by duration of contact. Duration of contact. So, the longer you are exposed to the chemical or the burn or the heat, of course, the deeper the involvement. So here are your burn depths. Okay, so remember this, ha? 1, 2, 3, 4, 5, 6. Basta kung char na, 6 na. Ha? Char zone. Okay, so for the burn zones, so it's usually the zone of coagulation, which is the central area of the burn, which is in most cases or in all cases, the point of maximum injury. So maybe that's where if you hold a hot pipe, no? Pipe, whatever. So the areas that came into direct contact, could be the zone of coagulation. And then in between is the zone of stasis, and in the periphery, zone of hyperemia. Now the difference between these three zones is the zone of coagulation, wala na. The proteins there have already been coagulated. So they're not the normal tissue anymore. Zone of stasis could be transitional. So there is marked vasoconstriction in that area. That's why that area is going to be pale. So the thing is, if resuscitation is adequate, then the zone of stasis might survive. But if inadequate, then the zone of stasis, there's a high chance that the zone of stasis is also going to necrose. Okay, so remember this, huh? Okay? 4.5, 4.5, 18, 18, 18, 9, 9, 1. Ha? Pwede mo malibog 18. Okay? Dapat panagit ni. Salitado na rin inyong multok. Of course, for pediatric, it's a different story. So you see patients, no? They come into the emergency room because of a burn. You would approach them as you do with any trauma patient. Because trauma is a special, burns are a special kind of trauma. They can also happen with trauma. Pwede man, kagan, then napasok, then nahulog, no? So na-fall, napasok, so combination. So first, of course, you are going to evaluate the airway. Now in patients with inhalation injuries, you will already be able to see certain signs. Maybe there's nasal fibrosate. The mucosa, nasal and oral mucosa might be edematous. The patient could have carbonaceous sputum. Then the patient might also be in distress. Could be wheezing and then heavy crackling. You also need to evaluate other injuries. Like I said, for example, pwede man sa let's say, you're trapped in your apartment, nasunog. Then you go and save your notes kay mag-exam by month. Then, while attempting to escape, nahulog ang aparador sa imo. Then, knock out. Then you woke up na naka sa stretcher. you were safe. Pero yung notes na wala na. Okay, but anyway, if that would happen, then you would also have to evaluate other injuries present. So maybe you can see external signs, or you can just ask the patient, because some of the patients could be ambulatory when you see them. Some of the patients could be comatose, no? Maybe ubusan TCS, tulog, unconscious, no? So you also have to estimate the burn size. So you saw the charts earlier. And diagnosis of carbon monoxide or cyanide poisoning. Especially in flame burns, no? You're trapped in the building and then there's smoke. Okay? And then, if you have a patient with any of this category in your text, no? More than 10%, partial thickness burns, involving the face, joints, genitalia, etc., with comorbidities, inhalation injury, etc., that's when you are going to refer to the burn center. So not all hospitals are burn centers. Yeah? Some hospitals may have to improvise in order to be able to deal with burn patients efficiently. The only burn center here is at NMMC. But of course, the other hospitals, pwede man i-makeshift ang room and everything to make it suitable for a burn patient. Okay? Antibiotics are not routine. Okay? Tetanus prophylaxis is important for all burn patients. So you consider it as also a profession. Now, sometimes though you might need antibiotics. Like let's say for example, you get a patient who was in flame burn, 20% EBSA, 1 week ago. Tapos siya sa bukid, kaya siya nabalhin din. And then, upon examination, you see that there's already virulent material on the burn scars, and then the patient is febrile. So maybe in that kind of scenario, you can see that the burns have become infected, and that's when you would need antibiotics. But initially, if you see a patient like that, burns, that you don't need to give antibiotics. Huh? Because topical burn management is going to prevent the infections from happening. Okay? Or it will minimize the chances of infections from happening. So for inhalation injury, these are potentially lethal. So patients can have acute pulmonary edema. There would be swelling, there could be effusion, and then there could be cytokine accumulation. So surfactant is going to be decreased because the pro-inflammatory cytokines are going to be accumulated. So there's mucosal edema in hypersecretion of mucus. Because of this, air entry and there is going to air entry into the alveoli, and then ventilation perfusion mismatch is going to be really bad at this point. No? So in most cases with inhalation injury, you would need to intubate these patients, because most of these patients are going to come in distress with respiratory distress symptoms. Maybe they have a low GCS, they're already wheezing, gasping for air, and then breathing is labored. So intubation. So another thing to be used is pulmonary toilet. So what is pulmonary toilet? Toilet bowl. Nainig toilet bowl. Para malimpyo ang toilet bowl. No? So pulmonary toilet is basically infusing saline or any isotonic solution into the airways of the patient and then suctioning. So what it does is it will aid in suctioning excess secretions so that the airways are going to be cleared up. So, since the airways in a patient with smoke inhalation injury are edematous and have a and are hypersecreting, you will have to deal with that. Mucus, if it accumulates for a long time in the airways, is going to become snot. So there can be a mucus plug that could be formed, and it could further obstruct the airways, thereby preventing further ventilation. Okay? So, an important thing with patients who you would suspect that have smoke inhalation injury would be, if you would, let's say for example, if they're unconscious, you can check maybe their nasal mucosa or oral cavity. So those could be clues maybe. Because some of these patients with smoke inhalation injury or suspected to have smoke inhalation injury would be brought to you unconscious. Then if you see, intubate. So, another thing to consider is cyanide poisoning. So cyanide is the ultimate poison of tau because it inhibits cytochrome oxidase, so it's at the mitochondrial level. Yeah? Now the treatment, you can give sodium thiosulfate to the patient, give supplemental oxygen, and give hydroxycobalamin. Now, these patients with cyanide poisoning, most of the time, will be in mechanical ventilation. So, the volume would be at 6 milliliters per kilogram body weight. Now, usually we give 10 mLs per kilogram body weight for the O2, tidal volume, but we have to bring it a bit lower to prevent ARDS from becoming more severe. Yeah? So for most burn patients, you would need to resuscitate. But not all burn patients would need fluid resuscitation. Especially, let's say, for example, 5% burn. And then, dali lang sa thigh. Are you going to do a Parkland and all of that? No need. No? Pero na patient. So, for patients with a TBSA involvement of 40% or more, you would need faster or rapid correction or rapid resuscitation. So maybe you can put 2 IV lines in the patient. So the infusion of fluids is going to be faster. If a patient has less than 15% TBSA of PERTs, then oral hydration can suffice. Yeah? For children, less than 20 kilos, you would have to add glucose because they have lower glycogen stores compared to adults. There's a problem then, there's a challenge among pediatric patients in inserting IV lines because their veins are very small, and another thing is, once you insert an IV line, pansan, no? They don't really understand their situations yet. So there are some methods of inserting lines which would be or let's say stable lines compared to the IV line. So it could be a peripheral catheter, central catheter, maybe of the internal jugular vein, or intraosseous. So it's usually done on the femur. So the femur is punctured down to the bone marrow, and then that is where the fluid is directed. However, an intraosseous line is only there to buy you more time because it can only be used for, I think, around 3 to 5 days. After that, it has to be removed because of the chance of developing osteomyelitis. So, you have the Parkland method, no? So, magic number na lang is 4. So, 3 to 4 milliliters per kilogram body weight per TBSA. So, 3 times weight of the patient times TBSA. American Burn Association recommendation is 2 milliliters per kilogram body weight per TBSA. Now, in some patients, especially elderly patients or patients with renal failure, lower volumes are recommended because these patients will not be able to circulate the volume efficiently. Thereby, it could result in fluid overload, maybe pulmonary edema, bipedal edema, or even worse, anasarca. Everywhere, no? There's fluid accumulation. So the most common solution we're going to use is lactated ringers. So maybe one of these days, kung paano mo DRs polymedic, at tawagan ko ninyo, mag-refer mo word, NSS inyo gigamit, ay kita mo pamalito at surgeon. It's lactated ringers, not normal saline solution. That's a common mistake done by a lot of, unfortunately, doctors. Diba? What is safer, NSS or LR? LR. Why? Because it has a composition closer to plasma. That's the only thing you need to know to make you say that it's safer. Okay? So for adults, the urine output goal is 30 milliliters per hour, but to be more precise, it's 0.5 to 1 milliliters per kilogram body weight per hour. So a 60 kilogram adult, 30 ml per hour is adequate. For pedia, 1 to 1.5 milliliters per kilogram body weight per hour. So we go to burn wound treatment. So first was the resuscitation, the fluid resuscitation, identification of other injuries and inhalation injury, and then go to burn wound treatment. So we start with topicals. The most common topical used nowadays is silver sulfadiazine. You can also use other compounds which are present in the market. So there's flavonoids, supernitrate, and for smaller burns, there are others. So there are also silver impregnated films. So there are dressing films with silver content, which can be used also in burns. There are also biologic membranes. So an example could be a amnion graft. So you get a placenta, get the amnion, make sure that negative ang HPSA, negative HIV before you can use it on another patient. That's one example of a biological membrane. You can also use a skin graft. That's another example of a biological membrane. So taken from a donor site, transferred to a recipient site. Nutrition. So if you remember in the first chapter that we discussed, nutrition is one of the most important factors after any injury, right? After an illness or injury, because the metabolic demands of the body will become increased. The REE, resting energy expenditure, is going to go up. So for burn patients, metabolic rates usually go up by 200%. So there is 35 to 40 kilocalories per kilogram body weight per day. That's the required, no? And then protein requirements are also going to be increased. So usually, normally it's 1.5 to 1, but in this case, it has to go up to 2.5 grams of protein per kilogram body weight per day. So for burns, however, with a less than 40% TBSA, you can use this formula here. 25 kilocalories per kilogram body weight per day plus 40 kilocalories TBSA. So another thing to compute later on. Beta blockers on pediatric patients are used because sometimes they become anxious, no? And then oxandrolone. Oxandrolone is an anabolic steroid. It's weak. It's a weak anabolic steroid, but it has been shown to prevent muscle degradation. So this drug is abused by bodybuilders, especially the female bodybuilders. And you have to prevent hyperglycemia from happening, because for any disease state, hyperglycemia is always associated with increased mortality and morbidity. So you treat the patients in the ICU or the burn center or the burn unit. There are some things that you would have to look out for. First, ventilator-associated pneumonia. So, if patients are intubated for a prolonged period, there is a high chance of developing ventilator-associated pneumonia, because with an endotracheal tube in place, it is going to decrease the functional surface of the airways, affecting clearance. Diba? The moment the air enters the nose into the vibrissae, that's when it starts. And then the ciliated epithelium in the upper airways, and then it goes down. All of those have been replaced by an endotracheal tube. So, it is possible for some pathogens, especially in the hospital, kusgan man kayo ng mga bacteria na nanabing sa hospital yun, no? They might enter and then cause problems. So, for patients with ventilator-associated pneumonia, you need to exercise what we mentioned earlier, pulmonary toilet, no? In order to clear the airways of excess secretions and to assure that the endotracheal tube is patent and has a low bacterial count. And also, watchful maybe observation of the patient is going to be done, so that you might be able to intervene as necessary. Maybe change the antibiotics or change the mechanical ventilator settings if there's going to be any complications. Abdominal compartment syndrome. So, this can happen usually 3 to 5 days or more after certain injury or burn, for example. Now, what happens here is the abdominal components are going to swell, especially the bowels, they're going to swell, and then the burn eschar on the skin is going to become less elastic, and it is going to form a tourniquet effect on the torso. So the thing is, it is going to compress the abdominal vasculature, resulting into a decrease of perfusion in anything below that point of compression. So what is done is we have to release the pressure by performing a decompression laparotomy. So you just open the abdominal wall and then let everything hang out. Of course, not hang out, but basta everything is open, and wait for the swelling to subside, then you can close the abdomen again. Deep vein thrombosis. So some patients with burn injuries are going to be bedridden for a significant period of time. So one of the consequences of inactivity, especially with mobility, is going to be deep vein thrombosis. Now you would want to prevent this from happening, because a deep vein thrombosis, once it gets dislodged, can go to the pulmonary artery, causing an obstructive form of shock. Right? You remember the chapter on shock? So, pulmonary artery thrombosis are usually fatal, no? When they happen to patients. Heparin-associated thrombocytopenia. So, some patients might be receiving heparin, and then because they have a long long staying catheters or because of the injuries present. So with the chronic exposure to the heparin, the platelets are also going to go down. But it is reversible if you remove the offending agent. And last, catheter-related infections. So maybe a central line, peripheral line, a Foley catheter, or whatever catheters are in the patient. So if they are on the patient for an extended period of time, they have a higher chance of being colonized by bacteria, causing catheter-related infections. So what is usually done is removal of the catheter, sending the catheter tip to the laboratory for gram stain and culture, and then replacing the catheter with something else at a different site. So for example, if you use the right internal jugular vein as a central line, it's infected, remove it. So you can't use this again. Maybe you might use the femoral vein or the left internal jugular vein. The role of surgery, of course, would be to remove necrotic tissue, so debridement. Because this is going to serve as a breeding ground for bacteria, for infections to develop. No? That's why you have to remove necrotic tissue. And to release the tourniquet effect of eschars. So as we mentioned earlier, for compartment syndrome, so this picture at the top is an example of an electrical burn patient. Grabe yun ang voltage. So, as you see, look at this table over here, this chart over here. You can see those lines of excision where you can cut so that you can release the pressure that the eschars are compressing over the internal or the underlying tissues of the body. This one below is an example of decompressive laparotomy. No? The abdomen is open and the abdominal contents are just left to bulge outside. So when the swelling is going to subside, then you can repair. You can close the wounds again. Okay? Wound coverage. Skin grafts, skin flaps, allografts, xenografts. Okay? So allografts are from the same species but not identical genetic composition. So maybe you and you. No? Xenografts from other animals, other species to human. Flaps. So flaps can be created to close certain wounds. Like maybe it would be more beneficial for the patient if we do a flap compared to a skin graft, because a skin graft cannot be done in certain areas wherein there is exposed bone, tendon, or paratendon. Bone, tendon, paratendon, you have those exposed, you can't put a skin graft over it because it will just necrose. The easiest method, of course, is going to be letting the wounds heal by secondary infection. Kaganihan pa niya. So that's for wound coverage now. Okay, so xenografts, allografts or xenografts are usually temporary. If you are not able to produce a wound coverage from the patient themselves, then you could resort into using a xenograft or an allograft, or you can use synthetic materials. So some burn patients might require rehabilitation after their injuries. So I remember I had a patient, I think 3 or 4 years ago. What happened was, summer, then ngat-kat ng kahoy, kaya sila mangga. So yan di, naman day power line. So his entire left arm got burned. Pero mga second degree lang. But the problem after 3 months, 6 months, he developed contractures on the fingers. So he had a hard time in flexing and extending his fingers. So I had him go to rehab. So after some time, might improve, but it's not 100%. So burns, especially if they affect joints, would cause contractures, but not all burns. It depends on the depth of the burn. First degree, second degree, superficial, most likely wala yun as like scar, no? Or contracture. But deeper than that, there's a high chance of developing contractures. So maybe you've seen people somewhere in the street, you're just walking and then a random person show up that may mga scar na rin, nakaanan na yun, no? May torticollis, and I burn scar na rin. So that's one example. Okay? So in order to minimize or prevent these from happening, the patients have to undergo rehab. So maybe it's usually range of motion exercises. So move one side, the other, because as we know, burn scar tissue rather is less elastic, and then later the phenomenon known as wound contraction would happen. So if wound contraction would happen, so the burn is here, and torticollis na, pseudo torticollis. So there's a contracture. No? Another thing would be psychological or psychiatric intervention, because some of those patients would have a near-death experience that would have a significant impact in their lives. So, refer ninyo kay Denson Go. Late complications. So, there can be hypertrophic scars, contractures, and heterotrophic ossification. So, for hypertrophic scars, watchful waiting like that. So, you know the difference between hypertrophic scars and keloids, no? Umanaman-mana, di ba? Wala pa. Basta, won't healing. So anyway, for hypertrophic scars, it's usually a cosmetic issue. But if the scar would affect the range of motion of the patient, then you can release these scars, maybe doing a Z-plasty or W-plasty. Heterotrophic ossification, so there can be calcium deposits on joints or on areas, but if they are usually on the joints and they are causing problems, maybe that ossification can be excised. Okay, this is what I just did. So prognosis, so for burns, it's dependent on age, burn size, and inhalation injury. If there's another form of injury done, or if the patient has any unstable or stable comorbidities, maybe post-AMI with heart failure, something like that. So if patients have these factors, then more often than not, then the prognosis becomes poorer. Okay?